When we make these the first time, we mold these not only to the foot, but we have a method we reheat it and we mold it as a person walks. That way we capture the unique walk that the person has, and then when they come back for the second adjustment, which is between 2 to 3 months, then we are actually focusing on repositioning the bones of the foot.
And Dr. Tesi, how often do you recommend that someone have their orthotics adjusted by you?
Generally, it's about every 3 months. If we're trying, the earliest we ever do it is 2 months. The first time we generally do it after 3 months because there's a 6-week very slow break-in period. The break-in period is not for the feet, it's for the knees. Because the knees operate like this, and when we're controlling the foot, the knees are basically, as the foot breaks down, the way I see it, they're out of alignment. So when we bring these orthotics, we bring the knee back into alignment, which is really good, but we want to give it time for the cartilage to adjust to it. So we do a very slow break-in, only an hour a day for the first week, 2 hours the second week. The orthotics, the way we make them, they have no fudge factor. When an orthotic is made by a lab and a cast is taken of the foot and it's sent to the lab, they'll fill in the arch a little bit to make the orthotic less corrective and also make it less dangerous because of too much. We don't do that. We make these orthotics exactly the way the foot is. The first time we adjust them, we're just basically holding the foot steady. The second time we're actually manipulating the foot. So we want to be very careful because we're actually changing the way the bones are in the foot. We're actually pushing these back. The orthodontics, which are orthotics for the teeth, that's what they do. You have the teeth and you go in and they keep tightening them and adjusting them. Well, that's what we're doing with the foot. So we actually are they're making it better. We're starting from a certain base and then we continue to manipulate them and we continue to make it better. Very different than the way we were taught in school. The way we were taught in school, I don't think works very well.
At this time, he's lifting the chair and molding the orthotic back to my foot.
Now when I'm pushing on this and adapting, I am focusing on putting the foot where it needs to be, the bones, pushing them up as much as they can handle. And there's an emphasis on here. A lot of people don't realize this arch is very important. The shoes that we wear allow the foot to collapse around behind the second toe and third toe, and the metatarsal bones come down. We're actually re-putting that back because that's where a foot should be. So we're pushing, that's one of the emphasis. We're pushing that bone back up as well as establishing the outside arch, which a lot of people don't think of as an arch, but I think it's one of the most important. And if you don't stabilize that, you really can't stabilize this. So this arch, the whole aspect, and this arch is where we're focused on. Then we tighten it so it holds better. Very important. Totally different than what we were taught in school. What we were taught in school was you put a plaster cast on somebody or have them step in a foot and you push up on this bone here, holding this in a joint neutral, and then you fill this arch. And I think the reason a lot of podiatrists stop doing those is because patient dissatisfaction. If I remembered the statistics that I was taught in school, they said 25% would consider that the orthotics worked good. 50% they got an improvement. 75, the other 25% poor, and 25% didn't work at all. With doing the method like this, I very seldom have somebody who's dissatisfied. Very, very seldom. And if they are, if there's a problem, because it's heat moldable, I can redo it. And that way they get a tremendous degree of correction. And what my patients have told me, it isn't just their feet, it isn't just their knees, but their lower back gets a lot of benefit. And as
I know
I've
my
shared,
hips.
yeah, you're one of the examples. I mean, I have patients who actually come in and tell me they want their orthotics manipulated, that their feet aren't hurting, but their knees started hurting again, and they need the orthotic adjustment. We use a material that is flexible, and so it allows the foot to still operate basically normal, but also allows us to push the bones back into position without it being super rigid. So even though when we make the orthotic, they fit as tight as the sock, there is no fudge factor here, but yet it is the way the foot is meant to operate, and it has enough flexibility that it can do that without putting abnormal pressure. So whereas people say, oh, that's going to be hard, they don't feel it.